Assalamu alaikum. This is Dr. Amna, and I will discuss today the spinal cord uh, pregnancy with the spinal cord injury. And this presentation is made from TOG article from 2014, and this is very important topic for the part 2 and part 3 point of view. For part 2, they can add the different levels of spinal cord injury, and they will ask that what sensations are not present in this patient, what are the morbidities at spinal injury at this level. So in this presentation, this is basically spinal cord injury due to accident. If patient is having some accidental injury, spinal cord injury can be due to accident or due to spina bifida. Because in part 3 station, if patient comes with the spinal cord injury, you should ask that I want to know about your condition. So don't say that I can see you are on wheelchair, or if patient needs to know wheelchair, or you ask, I want to know about your condition. So she will tell whether she is having accidental spinal cord injury or she is having spina bifida. And she was having multiple surgeries, but there is still spinal cord injury at some level, and she's not able to do a lot of things. So you will ask, are you aware at what level there is a spinal cord injury? So basically, whenever the patient with the accidental spinal cord injury asks you, what are the risks of congenital malformation in my baby? So with this spinal cord injury, there is no risk of malformation. But if patient is having spina bifida herself, there's a 5% chance that her baby can have spina bifida. So for that, we will obviously spinal cord defect, the open neural tube defect can be diagnosed on ultrasound. So there are 2 points about the spina bifida. One is a patient is, if having accidental spinal cord injury, she will have 400 microgram folic acid. But if patient is having spinal cord injury due to spina bifida, she will have 5 milligram folic acid. And patient is having increased risk of congenital malformation and open neural tube defect in spina bifida. So we will, and if the patient asks, there is a question that patient asks that I want my baby to normal. So I want to, you have done ultrasound, okay? So she may come after 20-week scan, and she says that it shows that my baby is normal, but I want to make sure that my baby is normal. I want to be sure 100%. So whether you will say, because it is done by an expert hand, it's 100%. No, you cannot say. You can say that it shows that there is no defect in the baby. However, 5% of congenital abnormalities are not detected even with expert hands. Even you do repeat ultrasound multiple times, you cannot be 100% sure. So up till now, it shows there is no defect. Okay, so you will increase the dose of folic acid with spina bifida. So a spinal cord injury is defined as an insult to spinal cord resulting in a change, either temporary or permanent, to its motor, sensory, or autonomic function. Management is based on the level of injury as well as the spinal cord injury being complete or incomplete. Obstetrics is high risk in this population because of spinal cord injury associated morbidity such as autonomic dysreflexia, spasm, contracture of the pelvis, decubitus ulcer, urinary tract infection, and respiratory infections. So level of lesions and effects. These questions can be asked in the part 2 exam. So levels above T4, a ventilation assessment in pregnancy is advised. Above T6, low baseline blood pressure, a rise of 20 to 40 millimeter of mercury is diagnostic of autonomic dysreflexia. Autonomic dysreflexia is kind of tongue twister, and I have explained it in further slides, and I will talk about it in detail because this is one of the major risk factor in these patients. So risk of autonomic dysreflexia in labor, and above T10, altered perception of fetal movement, unable to feel labor pains, and late preterm labor and UTI. So how we will manage all these complaints, we will see in next slides. Above T12, increased risk of malpresentation at term, whether it's breech or transverse above L2 and L4, scar tissue in the epidural space causes inadequate epidural analgesia. Following are features associated with all levels of spinal cord injury. So all levels, whatever level of spinal cord injury, these are the common risk factors, common features. An increased risk of anemia, increased microcytic normochromic anemia, an increased risk of pressure ulcers, requirement for adequate analgesia for an operative delivery, and perineal repair. A VTE score of 1 for immobility for wheelchair users. So effect on pregnancy, how these symptoms will affect, cause further problem in pregnancy. In the respiratory, if the patient is having respiratory problem above level injury T6. So excess bronchial secretions, reduced mobility can cause ventilation perfusion mismatch, increased susceptibility to pneumonia. Cardiovascular system above T6, bradycardia 40 to 50 beats per minute, hypotension 80 to 50 millimeter of mercury. In the genital urinary system, increased risk of calculi, urease producing bacterial infection, increased risk of UTI due to long-term indwelling catheter, and increase in frequency of stasis and incontinence. In bowel, constipation due to increased transit time and long-term opioids can cause autonomic dysreflexia. In bone, osteoporosis of immobility, endocrine, risk of gestational diabetes or undiagnosed type 2 diabetes mellitus. In skin, atrophic pressure ulcers, and hematology, normocytic normochromic anemia, and thrombosis, high risk in acute spinal injury, and psychology, so increased risk of mood disorder in pregnancy. For the thrombosis, high risk in acute spinal injury, I have mentioned before that a wheelchair user will have thrombosis score 1. But if patient is pregnant and she is having spinal cord injury in the pregnancy, so it is a increased high risk for spinal cord thrombosis, because in the first 3 months of spinal cord injury, there is a very high risk of thrombosis. So what is autonomic dysreflexia? This is very important thing, and we should understand it thoroughly, because when there is any spinal cord injury, basically the higher neuron cannot control the spinal cord. So basically there's a sympathetic nervous system in the spinal cord, and inhibitory neuron in this higher center comes, and it inhibits the sympathetic flow from the spinal cord. So this control is gone. Now sympathetic system is free. There is no control from the higher center. So autonomic dysreflexia result in disconnection of the sympathetic nervous system from supraspinal regulation, disabling the negative feedback loop. So it happens at injury at T6 or above. A noxious stimulus below the level of spinal cord injury will result in uncontrolled sympathetic outflow below the level of the lesion. So what are these basically stimulus which can cause the autonomic dysreflexia in these patients? These can be very minor, like fetal movement, like menstruation. It can due to sexual activity, constipation, full bladder. These things, even labor pain, these can cause autonomic dysreflexia. So what happens in this condition? So this caused a rise in blood pressure, activating the vagus nerve via baroreceptor that has reset to fire at a lower blood pressure since the spinal cord injury, causing bradycardia. So this is sudden rise of blood pressure from 20 to 40 millimeter from the baseline. We will establish the baseline first in these patients, because in these patients, baseline is very low. In normal state, baseline is very low. So whenever there is patient may have autonomic dysreflexia at blood pressure 120 by 80, because our baseline is very low. So we will record the baseline, and if any stimulus cause rise in blood pressure 20 to 40 millimeter more than that, it can cause this emergency, medical emergency. So we need to lower the blood pressure. There are two things we will do. First, we will find what is the stimulus, whether it's full bladder, it's constipation, fetal movement. Obviously, you cannot change fetal movement, but still there is whatever we can identify and we can remove. And if there is not any removable thing, then you will give the medication to control the blood pressure. Because if you don't control the blood pressure, it can cause cerebrovascular accident and more severe consequences. So autonomic dysreflexia is a medical emergency and can be fatal. Symptoms of AD: nausea, anxiety, malaise, prickling sensation in skull, ringing in head, throbbing headache. So I will explain all these symptoms in the patient language as well. So when you will consult the patient in preconception clinic or in the antenatal period, you can explain the patient what is autonomic dysreflexia, how it feels, and what should you do in this condition. So signs of autonomic dysreflexia is sweating, blushing, piloerection, tremor, nasal congestion, increased spasm, twitching, increased blood pressure of more than 20 millimeter of mercury above baseline, papillary dilatation, transient loss of consciousness, retinal bleed, and subarachnoid hemorrhage, cerebrovascular accident, stroke, and death. Fetal signs are fetal bradycardia with autonomic dysreflexia in mother. So treatment of autonomic dysreflexia is by removing the noxious stimuli or medical management in the absence of an identifiable trigger. Nifedipine sublingual capsules can be given, GTN patch or spray, 2 to 3 puffs, nitroglycerine 2% ointment to the skin above the level of lesion, 1 inch of ointment, and IV labetalol 20 to 40 milligram, IV hydralazine. You will lower the blood pressure then. So delayed or suboptimal management can lead to maternal intracranial bleed, death, and fetal bradycardia or heart rate irregularities due to paroxysmal hypertensive episode. You should distinguish autonomic dysreflexia from the gestational hypertension, because in the gestational hypertension or preeclampsia, there is sustained rise of blood pressure. It's not like fluctuating. And patient will have other symptoms as well, preeclampsia and proteinuria and edema, other factors of gestational hypertension. Autonomic dysreflexia is just a spike which comes and goes. An early sign of AD, rising blood pressure in a tetraplegia, is frequently missed. Why it's missed? Because baseline low basal blood pressure, if we did not document the low basal blood pressure, we will not be able to identify that it is more than the 20 millimeter or 40 millimeter from above the baseline, and it's causing the autonomic dysreflexia. This is because of low basal blood pressure, and individuals' baroreceptors are set to fire at a lower level than in those without spinal cord injury. For example, a blood pressure of 120 to 80 millimeter of mercury in a tetraplegic may be a sign of AD and would require immediate sublingual nifedipine if the cause of AD is not identified or removed. In patients, obviously, if it is because of fetal movement, you cannot remove it. In patient with a history of AD, a prophylactic epidural is recommended early in labor, because in the labor, there is a continuous labor pain, and also you will examine the patient, do the pelvic examination. It will increase the chance of having autonomic dysreflexia. So you will do it, do the prophylactic epidural, and you will gently examine the patient. So pregnancy after spinal cord injury. So what we are we have known all these side complications and all these things which patient might have in pregnancy. So we are prepared for that. Whenever patient comes for the preconception advice, so we will ask, ideally we will, I have mentioned in the previous presentation that we will ask the patient to become pregnant when she is best of her physical and mental health. So this is a rule for all patients. So whenever patient is having prior some medical condition, so you will check the medication of the patient, whether she is having any teratogenic medication. You will ask when was her last visit from her consultant of that respective medical condition, and did he know that she is getting pregnant? Did he ask her that she's fine and she can become pregnant? And we will check last investigations. We will make sure that this patient is in best of her health, and then we will give her folic acid and ask her to stop smoking and alcohol and increase her general health, mobilize the patient. So this patient is, as this cannot be mobilized, you can ask whether she is doing physiotherapy and what are the risk of frequency of infections, urinary infections, and constipation. We want to make sure that patient is in best of her health. So preconception care, ideally a planned pregnancy is recommended after physical and emotional rehabilitation is complete. Age and extent of spinal and pelvic injury assessed. Review medication for potential teratogenicity. Counsel about psychological and practical aspects of being a disabled parent. Woman's understanding of her condition, folic acid 400 microgram. So MDT care, we will tell her that you will be seen by MDT. MDT care comprising an obstetric, anesthetic, spinal nurse, specialist midwife, nurse, physiotherapist, occupational therapist, and named spinal surgeon, spinal consultant. Delivery in obstetric unit. And these are the main points we will discuss in preconception care. So she knows, have the overview of her total pregnancy. Then we will discuss in detail. Anesthetic review early in pregnancy, carer support that she's having any care at home, or her partner is supportive and she has anyone regularly visiting her at home for physiotherapy or mobilization and social services. She needs help from social services or not. Ideally, a vaginal delivery is planned. Admission to delivery suite early in labor. Information regarding websites and forum to have further information about the pregnancy with spinal cord injury and adoptive equipment. For example, low baby changing tables, wheelchair friendly proms. So next, nature and the limitation imposed by her disability, like autonomic dysreflexia, we will discuss with the patient. Pelvic contracture, it will be there. Injury to pelvis. We will record baseline blood pressure. This is very important. Review medication, change teratogenic medications, worsening mobility with advancing age, pregnancy, worsening breathing with advancing pregnancy, possible change of bladder care, may need an indwelling catheter towards the end of pregnancy. Regarding change of medication, I would like to emphasize here, because if another consultant has prescribed a medication for her medical condition, and you think it is the main drug to control these conditions, you will not change the medication on your own, because it's a preconception care. There's no emergency. You will ask you can fix her appointment with her consultant, so that she can discuss with him how to change that medication. Then we will further go. Booking visit, or if you have explained everything to the patient and you have given folic acid 400 microgram. If she is having accidental spinal cord injury, if she is having spina bifida, then 5 milligram. So in the booking visit, when patient is pregnant, she comes here, we will discuss all the details again, that how, because if she forgets, she can remember again what she is expecting in the pregnancy. No increased risk of stillbirth and congenital malformation in spinal cord injury. Women are assessed by dedicated consultant obstetrician in the first trimester, referred as necessary to members of MDT. MDT, what are components of, how many people are involved in MDT? Obstetric anesthetic, spinal nurse, specialist midwife, nurse, physiotherapist, occupational therapist, and named spinal consultant. I have mentioned it in preconception visit. Concurrent care with an obstetrician and community midwife at her local hospital, so that she does not have to come again to the hospital. She can get maximum care in her area nearby. A dating scan is recommended, and investigation like 10 to 13 weeks, 13 plus 6 weeks, we will do the dating scan, investigations, blood, HIV, like routine care, HIV, syphilis, and hepatitis B. And we will offer her a screening, aneuploidy, like Edward, Down syndrome, and PETAO. These are regular. Care will also be there. Obviously, we will not only focus on pregnancy with spinal cord injury. She's entitled to have normal care. So record baseline blood pressure. If there has been spinal cord injury at young age or pelvic trauma, clinical pelvimetry is performed, if not performed at the preconception visit. CT pelvis or MRI pelvis are not usually requested. So if patient has history of spina bifida, increased risk of neural defects, 5%. If the parents are having, and if sibling is affected, 15%. High dose folic acid 5 milligram, 5% congenital abnormalities cannot be picked on ultrasound, even with expert hand. So if patient needs 100% surety, you cannot give the 100%. So in the end, further antenatal care, we will have 20-week anomaly scan. Leon about T10, perception of fetal movement is altered. So you can teach, patient will be taught that how to feel for movements. She can put hands over her abdomen and she can feel the fetal movements. Perception of uterine contractions are also altered in Leon above T10. Women are taught to palpate fetal movements and contractions. There is a high risk of breech or transverse lie, especially in Leon above T10. These women will have contact number for spinal ward and delivery suite. RCOG guidelines on thromboprophylaxis, scoring 1 for immobility in chronic SCI. So you will assess the patient at booking, and you can make sure that she will be more properly mobilized. You can ask the patient to have pressure relieving mattress, and she can change of position every 2 hours to prevent ulcers. And obviously she will be mobilized as much she can with her condition. The incidence of urinary tract infection is increased in these patients because of stasis, and if there is a catheter in place, and if even not, then she is having risk of, if she is doing intermittent self catheterization, still she is having risk of urinary infections. So regarding urinary infection, whenever patient comes, you can do the complete urine examination, but a prophylactic antibiotic treatment is not recommended. So antibiotic treatment of asymptomatic bacteriuria is controversial. Not the prophylactic, even you should not treat the asymptomatic bacteriuria. It's controversial. You can or cannot. It depends. The discussion can be done in MDT and what they decide. So bacteriuria is only treated if it's symptomatic. This is the recommendation. That is cloudy urine, fever, frequent spasm, or AD, and significant pyuria. Meticulous bowel care, bowel bladder care. Bowel care means she should avoid constipation, fibers, laxative if she need. According to her need, we can make the plan. The use of pressure relieving mattress, position changes every 2 hours will reduce this risk of ulcer. So for delivery, a definitive plan is made for the place and the mode of delivery. So recommended hospital care from 36 plus 6 weeks of gestation. You will admit the patient at 36 plus 6 weeks of gestation, because she does not know properly. She does not know she's having contractions, and if there are contractions, she can have autonomic dysreflexia. So you do not want that. And you will admit it 36 plus 6 weeks, and also because you want to do daily CTG and 4-hourly monitoring for uterine activity. Vaginal birth is usual mode of delivery. This condition does not affect the mode of delivery unless there is a obstetric indication. Vaginal birth is a usual mode of delivery in women with spinal cord injury unless there is a suspicion of cephalic pelvic disproportion. A cesarean section booked at 39 weeks. The choice of anesthesia in labor always includes early anesthetic review. So general anesthesia is high risk in pregnancy. The risk of failed intubation in pregnancy is several times higher than in non-pregnant patient. So early epidural or combined spinal epidural in women susceptible to autonomic dysreflexia. In the first stage of labor, early epidural is recommended, especially in high Leon at risk of autonomic dysreflexia. A distended bladder, sometimes the result of blocked catheter, would trigger an episode of dysreflexia. To prevent this, if bladder management is not already by indwelling catheter, one should be inserted. So in the labor, indwelling catheter is preferable. Vaginal examination and insertion of indwelling catheter need to be performed gently with prior application of topical anesthetic to prevent triggering AD or spasm. Continuous fetal electronic monitoring. In the second stage of labor, spasm may complicate delivery. So this because muscular spasm is there because of sympathetic flow without interference from the supraspinal levels inhibition. This is overcome by optimal positioning depending on women's disability and preference. If autonomic dysreflexia is difficult to control in second stage, an instrumental delivery will shorten labor and remove the trigger. Third stage of labor, physiological or active management of the third stage of labor is indicated. You can do active management is always better because of it reduces the risk of PPH, postpartum hemorrhage. It's not necessary to avoid ergometry in women not at risk of AD. So it means that if woman is having the history of autonomic dysreflexia, you will not give ergometry. But if there is no history of autonomic dysreflexia, then you can. If you have to, you can give. So what if a patient requires cesarean section? So as we have mentioned that in the labor, we have indwelling catheter, and full bladder always cause problem, can precipitate the autonomic dysreflexia. So cesarean section should only be performed for obstetric indication. Lower segment cesarean section with suprapubic catheter in situ. Then we need some extra care. So the skin incision is made 2 centimeters above the suprapubic catheter insertion. The catheter is recommended to be changed 24 hours before surgery. Non-absorbable sutures are used for closing rectus sheath and skin to reduce the risk of wound dehiscence in denervated tissue. So this is the different from routine practice. We will use non-absorbable sutures to close rectus sheath and the skin. Skin is usually sutured using interrupted non-absorbable suture material. If a patient has episiotomy, no increase in spinal perineal wound breakdown above that in the general population. It has almost the same risk of perineal wound breakdown. Breastfeeding is normal in women with spinal cord injury, and in women with complete spinal cord injury above T4, the initiation of breastfeeding is delayed and requires additional stimulation such as visual stimulation or oxytocin nasal spray. Contraception, a combined oral contraception containing estrogen is not usually recommended because patient is not well mobilized, and there's also VT risk of one. And intrauterine device and female barrier methods may be used but need to be prescribed depending on the degree of the disability. If the patient is not in a position of patient cannot make the lithotomy position, then obviously you don't need, you cannot insert intrauterine devices. And female barrier methods are not, obviously they also need positioning, and also their failure rate is more. So we have option of progesterone only pills, progesterone injections or implants, female sterilization, and male contraception may be more appropriate. So this is all from the our point of view. For patient point of view, you can, I will just name the things we will need, so that when you can, if you know all the concept, that why folic acid and which spina bifida, if it's that, I will not explain right now. I will just enumerate the things, okay? And I will, in the end, I will tell how to explain the patient what is autonomic dysreflexia. So preconception counseling include folic acid, check for general health and support, bladder and bowel care. These are just points, you know the detail. Mental health, change teratogenic medications, review by a spinal consultant. And how you will explain autonomic dysreflexia to the patient, you should explain it in the preconception as well, and also in the booking and antenatal visit, so that check the patient understanding. Because it's a medical emergency. Autonomic dysreflexia is characterized by sudden rise in blood pressure. This is what you will tell to the patient, that this is characterized by sudden rise in blood pressure. The most common symptom of AD is a severe pounding headache. Other symptoms may include sweating, flushing face, goosebumps, anxiety, tremor, nausea, chest pain, shortness of breath or stuffy nose, and a slowed heart rate. Immediately look for the cause of AD, such as bladder retention. If your bladder is full, you have constipation and tight clothing, etc. What you have to do in emergency, you will sit up rather than lie down and lower your feet to reduce your blood pressure. Immediately reduce the amount of rearward tilt in your wheelchair. You will make the, you will lift the back of the wheelchair. So take prescribed medication if whatever, because she might have proper prescription. Obviously, she should have, and she should have medicine at home. Call an ambulance immediately if the symptoms are severe or increasing rapidly. So in the booking visit, you will do booking scan, investigations, and NAPLID screening. You know all these details. I don't have to tell it again. HIV, syphilis, and hepatitis B, NAPLID screening down combined before 14 week, and then quadrupler. Then anomaly scan and 20 weeks thrombosis risk assessment. In each visit, BP monitoring, complete urine examination, assess general and mental health, growth scan, palpation of fetal movement, early anesthetic review, admission at 36 plus 6 weeks, hospital delivery, early analgesia, continuous electronic monitoring, active third stage management, avoid ergometry if history of AD, contraception, spinal cord injury below T6 usually have no problem for breastfeeding. Thank you so much. Kindly write any question you want to ask. Thank you so much.